was ex in charge of critical care in RML and Mulchan Hospital. I get it correct, sir? Yes. I request Dr. JPS Tulsi sir to start the proceedings. Before that, I would like to felicitate the wonderful team of IBS. Sir, we have cups from Physician Forum of India. When you take your tea in the morning, you open that cup, you have your tea, and you see the motto of the forum. And can I request Dr. Sushu Talmas, the digital brain behind the entire effort of Physician Forum of India, to can you come here? Can you come here, Sushu? Dr. Sushu Talmas is a renowned radiologist. He is my batchmate from Maulana Azhar. He is a very scholarly person. He has made films.
Light jalana ya jala.
Mumbai, and he runs a very successful NGO in the name of his father and mother. I request him to honor Dr. Sachin Kandhari with the cup. And this is the finish of the people. So this is empowering doctors for a healthy India. Can I, Dr. Tulsi, where are you?
Sir, here.
I need a diary. Sir, we give you a diary from Physicians Forum of India.
Directory.
This is the who is who of South Delhi.
Directory.
Directory, I'm sorry. Yeah, directory.
Sir, please.
Thank you. So you stand here. We'll honor our on moderator, Dr. JPS Tulsi sir. He already has a directory, so we will give him the cup. After the Thomas cup, sir, you have the. Thank you. I would like to. We would like to honor Dr. Priyadarshi. Your talk will empower our doctors for the I would like Dr.
Sir, directly.
Yes, directly. So, it will be helpful to you with the numbers, telephone numbers, address of all these elderly doctors. We would like to honor Dr. Sachin Samuel. Directly, Dr.
Tulli थोड़ा साइड में.
Sorry.
साइड में हो जाओ.
Sir, you will have the IMA directory, DMA directory, but this is a special directory.
साइड में तुली.
I would like to honor Dr. Kishan Raj. Dr. Kishan Raj is a neurologist. He was the one who conceived this CME with me. We wanted to have a CME and directly. Dr. Kishan Raj is a very good neurologist, and I would like you to go beyond max and experience the wonderful skills of the team of IBS. Unless and until we associate, we engage, we refer cases, we do not know how good they are. So I would also like Dr. Sachin Kandhari to engage with us on a consistent basis. One CME in 3 years is not good enough. We need, I understand, sir, but we need at least 3 in 1 year. And I assure you, sir, and your wonderful team, marketing team led by Mr. Raju Beara, that do not give up, engage with all of us. Right? This is how things are in Delhi. Right? Over to Dr. Tulsi, sir. For his comments, for his moderation, and to take the CME forward. There are 5 speakers. I would request all the speakers kindly to stick to the timeline, because everyone here, apart from taking some good messages from you, are also very interested in having an early dinner and going back. 1 hour. Dr. Tulsi, sir.
Thank you, Dr. Chauhan, and thank you, Physicians Forum of India, for allowing me to moderate this CME today. So it's been 17 years of amazing journey with the EPFI. Learned a lot of things, and continue to learn as well today. As we have 5 speakers, as Dr. Chauhan said, I would request all my panelists here to limit their talk just to 10 minutes, please, so that we can have some Q&A after their talks. And the Q&A will follow after all the talks are completed. So to start with, probably Dr. Kandhari, we'd like to probably start your talk on neuromodulation neurology.
ठीक है सर, ठीक कंटिन्यू.
So at IBS being a neuro center primarily, so our focus is totally on enhancing whatever capabilities we can to aid diagnosis and treatment in neurological diseases. To add on to the recovery of patients post maybe stroke or head injury or spine injury, so we have introduced a novel concept of robotic neuro rehab. So this is region's first, Southeast Asia's first Cyberdyne center. So what is this Cyberdyne concept? I will try to explain in the. So this Cyberdyne is a robotic system which has to be worn by the patient. It is different from any other exoskeleton or something passive which makes you walk. But this is something which helps you learn to walk back again. So this is called HAL, that is hybrid assistive limb. Hybrid because it is partially motor and partially controlled by the patient's own intent to walk. If you remember 3 to 4 years back, it was in the news as you think about walking and the robot walks. So this is the same robot. The principle is that you think about walking, even in a paralyzed limb, when you have an intent from the brain to walk.
So can they enlarge that? It is small, full screen.
तो वॉल्यूम बढ़ानी पड़ेगी मेरा.
ये ठीक है, दिस इज ओके, फाइन, फॉर यू दिस इज फाइन. थोड़ा बेस कम कर दे, बेस पीछे आवाज भी कम कर दो. ठीक.
So how this limb works. So let us consider a scenario. We have a patient of say right MC infarct with left-sided weakness. So you first wear the robot and think about walking. That intention of thinking is then carried on to the leg surface, and there are sensors placed on the leg. That intent is then read by the sensor, conveyed to the robot, and that intention of walking is then performed by the robot. When the robot walks, that walking motion, that movement of the muscle, that coordination is then recorded and sent back to the brain. The brain then receives the same information. So you see the intent of walking has originated from the brain, starting from the brain, carried to the body, and then relayed back to the brain. So this is how you can, in even one session of Cyberdyne, you can see some motor recovery in stroke patient. I'll just play a small video of a patient that we treated, and that will help you understand better how it works.
क्या हुआ राहुल? तुम अपने पुराने वाले फॉर्मेट पे ले जाओ। हाँ, इस पे चला जैसे हो इसी पे चलने दो, कोई बात नहीं। इस पे हाँ।
So this is very interesting case of a 60-year-old man. So he had gone for a morning walk, and we don't know exact history that he fell down by giddiness or some trauma, and he had severe head injury.
हेलो
So he was brought to casualty in a comatose state. His GCS was around 5 to 6, and it was a Sunday morning. So luckily we were there for some other work, neurosurgeons. So he did urgent surgery. So urgently we did a surgery, but due to subacute hematoma and left side weakness, the patient was comatose and in ICU for at least 1.5 months. And after coming to senses and we could remove the tracheostomy and everything, still he was left hemiparetic, barely able to move the left side and with altered sensorium. So to initiate more recovery, then we prompted him to undergo neuro rehabilitation using robotics and Cyberdyne. So your 60-year-old man who was previously comatose for 1.5 months in ICU for 43 days, and then rehab recovery of 2 months. So now, as of today, as we speak, he's totally fit and fine, moving about. There's no deficit. He's not on any medication. So this is his present state. So now we'll take you through the. This is post-operatively when he was shifted to room after a month, still on ventilator. So this is him not able to walk, needing 3 people to walk and dragging his left side. Hand function also is impaired on the left side. This is Cyberdyne therapy where his intention of walking is being converted to motion by robots, and the brain is already being trained again to. Now, this is him in the beginning, then this is after 4 months of injury and 2 months of therapy. We have not seen any, always when we see the patient having head injury and 2-3 brain surgeries and weakness on the left side or right side, we have never seen that recover so well, so fast. To be able to play football, and I don't think anyone can tell which side was paralyzed before this football. So this we could achieve due to a timely surgery and neurocritical care and timely intervention by proper rehabilitation. So second, one small video I'd like to share about. There was this young girl who's beautician by profession, and she was shot in the back by somebody in the neighborhood since she got engaged. So they came to her house and shot in the back. So this happened around 1.5 years back. She was rendered totally paralyzed below waist. But in 1 or 2 months she had just some sensory improvement and some power in the hip, but she was not able to sit, move the legs or even stand. So then we started again Cyberdyne and other robotic neuro rehab. This is the only device in the world which has been US FDA classified as a treatment and not a therapy for incomplete spinal cord injury. So somebody who was not able to move even 1 centimeter, like just sensation were there, and now she's able to walk with some support of walker with no manual support. or also have bladder bowel control as return back. So whenever you do neuromodulation or you try to train the brain back, it's not only one aspect of it which is going to recover. It's not only motor power or something. There will be holistic improvement in the brain activity. So that is the principle. It kind of reboots the brain and promotes neuroplasticity. The area of the brain which was not functional before has been taught how to behave like a damaged brain part. So this is her walking now. So in 3 months she is able to walk on her own, have sensation of bladder and bowel, and have her balance back. So all the conventional methods we all know, practice, all of us have seen. Spine injury, somebody is not even living for 1.5 years. We don't see any hope in that. But here, without any surgery, without any medication, or it's only 2 hours of rehab 5 days a week for 2 to 3 months. That should recover so much. Thank you. Sir, any questions regarding the
patients at the end of
the end.
Thank you, sir.
So our next speaker would be Dr. Vikas Gupta, the consultant neurosurgeon, and he's going to talk on degenerative spine surgery, minimally invasive spine surgery.
Good evening, everybody. I'm Dr. Vikas. We are a team at IBS. Dr. Sachin, Dr. Gaurav, surgeons, and Dr. Harsh is here also, and Dr. Kishan, who is a neurologist with us. I have been told by sir to be very brief about everything, so I'll try to be brief. I know this is not going to be very long. But yes, I'll be just talking about basic things, minimally invasive spine surgery, which is a very in thing in today's times. Just a brief. Okay, so just coming to today's agenda, so we'll just review the spine anatomy and pathologies. What do we basically have in spine and what do we look at when everything goes wrong? And overview of minimally invasive spinal procedures, the outcomes of those procedures. And obviously question and answers, that would be probably at last. So just a basic thing, this diagram is basically a functional segment of the spine. So what do we have here, just to revise? So we have vertebral bodies which take the main load. We have the disc, everybody knows what is a disc, a cushioning material. And then we have facet joints, joints which make up the back portion and which join the individual vertebral bodies together. And they are responsible for motion as well as restricting motion. And then pedicles. Pedicles are the structures which connect the vertebra to the facet joints, the joints which join the vertebra together. Now, if you look at the gambit of it, so basically what do we see? With old age and degeneration, we see many forms of diseases in the spine. The most common or broad term is degenerative disc disease, so which is a naturally occurring process. Any organ ultimately goes through degeneration, and if it has been not handled properly, the degeneration is fast enough. So that's what we say, that we should be very careful with the spine, the posture and everything, and what you are doing with it. So it's a naturally occurring process which may become symptomatic in certain individuals, as told. The other thing is that common term, herniated disc, we know that herniated discs are there, which are slightly different than degenerative disc disease. And the other thing is spondylolisthesis, which is a slightly complex thing, and here the one vertebra slips over another, causing malalignment, major back problems, major pain in the back, and radicular pain also. So that can be mostly degenerative or age-related, or even congenital, and can be traumatic also, but that's an acute thing. And then in old age, most common is spinal stenosis, that is the narrowing of spinal canal, which presses the dura, the exiting nerves, and it can be caused due to abnormal motion in the bones, which leads to hypertrophy of the joints as well as ligaments around it. It is associated with aging, obviously, and then it can cause further narrowing of the foramina, causing the neural compression and symptomatic radicular pain and back pain also if joints are involved. So this back pain is basically due to facet joint osteoarthritis. Just like knee joints, we know knee joints are very commonly known as joints which have osteoarthritis. They need replacement, something like that. So facet joints are also synovial joints, which wear and tear with the age. The whole spine is made up of multiple facet joints. There is a cartilage which breaks down like knee joint, and it can result in hypertrophy of the joint, then encroaching up to the foramina, causing nerve compression. That is the basic pathology which happens with wear and tear and with age. So another condition which is commonly associated with spine is osteoporosis. We see lots and lots of osteoporosis, especially in Indian women, because of various things, diet and the habits. So bone mineral loss, fragile bones, and this osteoporosis augments or hastens the degenerative procedure of the spine very much. We see mostly in females, the spinal canal stenosis, the percentage of females is more as compared to males in our surgical practice. So coming to non-surgical treatments, they are there. The physical therapy, you keep on doing exercises, rehabilitation, pain medications, anti-inflammatory medications for the joints, chiropractic care, bracing. People are very liberal with that. Lumbar brace, everybody knows that we have to apply lumbar brace. Lumbar pad लगा लेंगे उससे पेन ठीक हो जाएगा, which is actually not the correct thing, but it is indicated in certain conditions, not every time. And behavioral modification, by that we mean ergonomic behavior, how you are sitting on your chair, how you are working, where you are placing your legs, what is the back support, all that alters and controls the back and the development of degeneration in that. So professions are linked with the spinal problems. We see lots of software people coming with cervical problems in young age or cervical disc even, and we see a lot of people who are sitting in gaddis of their shops for long hours, for years, coming with spinal canal stenosis, degeneration, facet arthropathy. More the joints are loaded, the disease presents like that. So just coming to minimally invasive surgical techniques. So there are surgical techniques which are routine, which have been done over the years, that we go, we remove the joints, we replace the joint with the screws, we decompress the nerves, we decompress the theca, and try to get a good canal. That's what the basic aim is. Now, but the minimally invasive spine procedure, there are advantages, and the conditions in which it can be used are the same as more or less we have been using open ones: herniated disc, degenerative disc disease, dystosis, stenosis, deformities, trauma also, and tumor of course. So the goal is basically to accomplish the same clinical outcome as traditional open surgery through a less traumatic approach. Candidates: conservative management, failure of course, and any patient who really needs surgery. And obviously it is beneficial for elderly patients because invasive procedure may have some complications in that, a bigger procedure. So it can be used in any level of spine, mostly used in lumbar spine, thoracic spine. Indications are less, then lesser cervical.
Please conclude, Dr. Vikas. Please conclude.
Okay. So we do decompression, fusion, and the benefits of these invasive procedures, less invasive procedures, are that they have shorter hospital stay, less blood loss, early ambulation, and then returning to work is very early. There are potential risks also that since you're operating through a small hole like this, so the problem is that you can injure the tissue because of limitation of space. So it really requires a learning curve to handle that, and that is the reason that it should be selected and done with the expert procedure. Now, example, this old approach versus new technology, the open and the new one, a small keyhole. So image guidance is required, and we don't cut through muscles, we dilate the muscles basically. And there are specialized instruments which do that. So dilators, which spread the muscles and you reach the desired area where you have to actually work, rather than cutting through it completely. So that's a tubular retractor, and we keep on dilators over dilators and dilators, and then we reach the desired level that is confirmed by fluoroscopy, and then we start the procedure. After that, a fixed tube is there through which that is our working port actually. I'll show you, this is how it is done. Through that tube, we use all the instruments with microscope. So I'll just be slightly fast. You can also do a fusion. For example, not only decompression, you can actually fuse, put in a cage, interbody cage to achieve a fusion in case of unstable spine. So that can also be done through this tube method only, or manually procedure. You don't need to open always to transverse process, big incisions, deep incisions. No, that can be avoided. So lateral approaches are also used. They can be also used through dilator systems. Then we have percutaneous fusions. You can place rods, which are very established systems, like Sextant system, gold standard, old Medtronics, where we can actually put in percutaneous screws and we can put in percutaneous rod and fix it then and there. You don't need to give a big incision. So that's the purpose of it. It's an arc-based system. It just arches and goes right then and there where it is actually required. But it can only work for 2 to 3 levels, not more than that. Then it was developed, another system was developed which was for multiple level fusion. You can do 8, 10, whatever levels, multiple screws. And that was a freehand system. That is known as longitude. That can also be used. It's also a technically very sound system. We have been using it, and it can be used, the advantages for many levels. It's not an arc-based system, it's a freehand system. You just place a freehand rod after placing percutaneous screws, it goes there and there only. I'll just show you some sample cases. This example for listhesis. This is just see the amount of incision required for a fusion done in a right way. So you can do all those things. You can put in T-leaf, you can put in cages inside with this percutaneous level also. But you require navigation. So this is the navigation we have with us in our hospital, the striker-based navigation, which we use for the spine. And of course,
we conclude.
Yes, we have a very good 3D CR, which is also useful for these things. So basically these procedures require a good armamentarium and learning curve, and they can really be very satisfying as a surgeon, as a patient also.
Very good.
Thanks a lot.
We'd like to have Dr. Kishan, an eminent consultant neurologist, and he's going to talk on management of acute strokes. Dr. Raj.
चालू कर दिया दोबारा चालू कर मैडम नहीं आई ना मस्त दारू हटा ले फिर खींचे
ये क्या बात हुई भाई?
वो वाली सारी टेबल नीचे बैठ के
Good evening, everybody. I'm Dr. Kishan. I'm a senior consultant neurologist at IBS Hospital, and I welcome you all on behalf of IBS Hospital. So I'm looking after the stroke unit at IBS Hospital. So I've been told by sir to go very fast in this, but stroke is a very comprehensive topic. So it has the treatment and paradigm has changed since recently. So I want to just, so this is the overview of the talk. So I wanted to go tell you about the neurovascular anatomy, localization of stroke syndromes, and then management of stroke, and then special emphasis on the intravenous thrombolysis, and an interesting case which I want to show to you. So, as you know that stroke is basically a cessation of blood supply of brain that could be due to occlusion of perfusing artery, which is called ischemic infarcts, or that could be due to rupture of that particular artery, which is called brain hemorrhage or intracranial hemorrhage. So 80% of time this is ischemic infarct, and only in 20% of time this is brain hemorrhage. So as you can appreciate that these are two CT scans. Like you can see this, there is basically a CT scan on the right side that shows hypotensity on the right hemisphere. This is basically right MC territory infarct. And on the left side the CT shows hyperintensity, which is basically intracerebral hemorrhage. So this is the circle of Willis, as everybody knows, so which consists of anterior circulation and posterior circulation. And anterior circulation basically is perfused by internal carotid arteries, which further divides into anterior cerebral artery and middle cerebral arteries. And the posterior circulation from two vertebral arteries, which joins to form basilar arteries, and later on that basilar artery divides into two PCAs, which are posterior cerebral arteries. So these are basically our stroke syndromes, depending on the artery which is blocked. So now coming to the treatment part. So management of stroke is divided into four major paradigms. So the rate limiting step is basically immediate management, which consists of in ischemic, I'll speak on ischemic infarct. So the rate limiting step is intravenous thrombolysis. So that is done within 6 hours of onset of symptoms, and that is the basically rate limiting step. Later on, the management is in subacute phase, which consists of basically management of all the vital parameters or other complications which we treat in subsequent phase. Then comes secondary prevention, and at the last there is rehabilitation part, which comes later on. So the immediate specific management is thrombolysis, which is done from 4.5 to 6 hours of onset of symptoms.
Dr. Raj, just a moment. Can we have some silence at the back, please? A lot of noise.
So I would like to just emphasize on the intravenous thrombolysis part. So what is intravenous thrombolysis? It is basically the process in which we give TPA, which is basically plasminogen activator. We give it intravenously to lyse the obstructing clot in the cerebral blood vessel. It is given within 6 hours of onset of symptoms, and the dose is calculated according to the weight of the patient.
Can we have some decorum at the back, please?
So the total process takes 1 hour, which can be done in SDU or ICU setup. So why thrombolysis is essential is the only available treatment for ischemic stroke. It limits the size of infarct by dissolving clot and restoring blood flow to the ischemic area. And if the thrombolysis is delayed, then it leads to degeneration of 1.9 million of neurons every minute. Every minute we lose 1.9 million of neurons if we delay this process. And this process can limit the long-term disability and mortality. So you can we can appreciate this. This is the picture of a CT scan at the onset of infarct. We can appreciate there is a pink area. So at the onset of the stroke, the pink area is the only degenerated brain tissue. But that blue area, that is the salvageable tissue. That is called the ischemic penumbra. So if we thrombolize at this stage, the blue area, which is called the ischemic penumbra, that can be saved. So now you can see after the 6 hours, the pink area has increased. It seems the degeneration of brain has proceeded, and the larger area has been degenerated due to lapse of time. So you can see the sequential CT scans. So the first column shows the CT scan at different axial planes at the onset of stroke. So we can appreciate that. And the second column, we can appreciate there is a right MC territory infarct. We can see the hypodensities. So this hypodensity is developing subsequently after 2 hours of onset of symptoms. So IV thrombolysis is a FDA approved therapy. So it has a 30% relative reduction of long-term disability at 3 months. But it also has some adverse effects, like there are 6.4% of chances of brain hemorrhage. So now I'm going to just show a case. So this was a 63-year-old male with a known case of hypertension. He was found unconscious in the market. So when he came to emergency, he was unable to speak. There was some facial asymmetry. There was left-sided weakness. So these are the vital parameters which were recorded in emergency room. The power in left upper limb was 0 and the left lower limb was 2/5. So he reached hospital within 2 hours of onset of symptoms. The initial CT scan was normal, but when the MRI was done, it showed right MC-territory infarct. So basically investigation of choice in this case in ischemic stroke is always a MRI scan with a diffusion sequence, because a diffusion sequence only can show the immediate infarct in the MRI. So we can appreciate this. This was the CT scan of this patient. We can see this is totally normal. We are not able to see anything in the CT scan. This was done when the patient came to us within half an hour. And now we can see this is the MRI. Simultaneously MRI was done. We can appreciate there is large right MCA territory infarct. We can see that. Now this is the T1 image which shows same infarct.
We can conclude.
No sir, I want to just show the videos. ये कैसे चलेगा अगला स्लाइड?
Alright, we can talk on the MCA later on.
No sir.
Alright, let's conclude. Thank you, Lord Christ. Let's conclude. We can talk.
Yes, thank you, sir.
Dr. Priyadarshi, consultant orthopedic spinal specialist, and he's going to talk on complex spine deformities. Go ahead, sir.
So just to show you, this is the pre-thrombolysis status of the patient. Patient is having right sided weakness.
उल्टा वाला हाथ उठाइए, उल्टा वाला हाथ, ये
Left sided weakness of upper and lower limb. Zero power.
दूसरा पैर उठाइए.
Now he was thrombolized within 2 hours of onset of symptoms. Second day after the 24 hours of the thrombolysis. The patient is walking. Patient is walking. So this is a large right MC-tating part which got resolved with IV thrombolysis. So I would like to request you, if you have any cases of acute infarct, so without wasting any time, you can send us to us. So this is the only treatment which is recently available. Thank you.
This is astonishing. We'd like to talk on large MC infarct later on. So Dr. Priyadarshi, complex spine deformities.
I'm just here to introduce Dr. Harsh. So Dr. Harsh is a new addition to us. He has joined us now for our complex spine surgeries and scoliosis program. We have been colleagues earlier in Max Saket. So our friend returning back to us. Take one please.
Thank you, Vikas. Good evening, seniors and colleagues. I won't take much of time because I can see that they are being served and I don't want to come in between. One, I can see lots of familiar faces, maybe from my senior consultancy in Max. So let's just consolidate things. I'm not going to teach anything. I'm here to share what I can help with. That's all I want to share. Okay? Let's start. So I'm not going into all this nitty-gritty. There's deformity, kyphosis when you have a hunchback, you have a lordosis, sway back, you have a scoliosis. That's the commonest thing when you see somebody laterally tilted or left and right. So scoliosis is very common, and you will see a C, just one-sided deformity, or a S-shaped, less-shaped deformity. But the main thing is idiopathic scoliosis or a degenerative scoli. Children, and you can't see much, so we need to see an adolescent face. What do we see? If it is 10 degrees, we see X-rays with 10 degrees of curve. Don't do anything. We just watch. 20, more than 20, we need to be very careful where we can brace. Okay? Idiopathic scoliosis, how do we say? That's no cause, but we have to rule out congenital, we have to rule out neuromuscular scoliosis, and all those stuff. And then we come to that. What are the symptoms? Now this slide, I just want to highlight that when a vertebra is rotated, it's not only this deformity like kyphosis or scoliosis, it's a combined deformity. So they have a rotation of vertebra. You can see the ribs. So what it does, it will compress your heart or the lungs. So it is compromised. That is what we have to be careful of. I'm not going for change in walking. Naturally, if you're tilted on one side, hip might get displaced and you will have your hand getting like this in the way. So these are the things that we have to watch for. Types, don't go into that. Infantile, juvenile, we would not see much, but adolescence, that's the quick growth phase. That's where the deformity has to be tackled. And if you don't do that, it will go on to the adulthood and you will have an ASA, that's adolescent scoliosis adult. So when it needs a treatment, observation till 25 degrees, we'll see, observe every 6 months, get an X-ray done. You are all doing that. If it is more than 25, if it goes on progression, that's where I'll help you. I can really help you there, and we can start with bracing. But bracing has a limitation. If the skeletal maturity has been achieved, bracing won't do anything. Okay? In few cases, surgery. That's the mainstay. Then we go for posterior spinal fusion. Why? Because we have more than 5 to 10 years of records now that they are safe and they can be done. All the more with all the implants that you were seeing with Medtronics and all the other companies, they have latest implants and we can really do wonders with that now. Surgical option, fusion, growing systems and fusionless. Let's see fusion. I've just talked about it and I'll show you the photographs. Now, no more teachings, but growing systems. What do we do? If there's a small baby, the fusion or that skeletal maturity has not been achieved, what will you do?
we have to keep watching that baby, and along with that, we also need to take care of the deformity. So there comes the growing rods and stuff like that. But there are some complicated situations. I'll share some pictures. Fusionless. This is the latest. We don't do fusion. Remember in old days, we used to put 2 screws and tie it with a wire. That's tethering, and that has come in forward now. But we don't have 5 to 10 years of record for that. So we'll have to wait for the really records there. Let's start with this. Okay, this is a primary thoracic kyphoscoliosis. You can see the deformity. You can see the latest, how the progression of deformity is there. This patient is osteogenesis imperfecta, 4 years female. Do you need to fuse? If you fuse a 4 years old female, the lungs won't develop, heart won't develop. What will happen? Ultimately death. So what we need to do? We need to do something that we control the deformity. Here, you can see there's a post there in the proximal section and the distal section. So we put pedicle screws in the lumbar spine, and we put pedicular hooks and transverse hooks in the thoracic spine, and keep it. Along with that, we put skull traction and keep it on the chair. This is a practical patient, 215 and 216. I went to Sydney in 216, and that's where we started to follow up with this patient. We put the skull traction in the chair, in the wheelchair, and we manage that. After that, we put in growing rods. So these are few events that we can help the baby with. We don't fuse immediately. So what is the goal? Still stop the curves projection, reduce deformity, main thing, maintain trunk balance. Whether the patient is like this, if the head is balanced over pelvis, finished, the patient can walk. That is what we want, head over the pelvis, balance. That's the main thing. Okay, this is the 16 years old female, adolescent idiopathic scoliosis. So you can see the curve, the thoracic curve, and that is progressing. In the second slide again you can see. So what we do, selective thoracic fusion. We don't fuse the whole spine, okay, but we selectively take the curve and we fuse it. And the person will be doing fine. Because the skeletal maturity has already been achieved. So fusion won't matter much. So for idiopathic scoliosis, that's it. But you have to rule out congenital, neuromuscular, degenerative, and we will do that in the next slide. So this is a congenital scoliosis. You can see a hemivertebra in the lumbar region. So L2. So you can see, भगवान भी एक मुसीबत एक साथ नहीं देते. अगर देते हैं तो पूरी बाढ़ देते हैं. So we have L2 hemivertebra. Along with that, you have 3 ossification centers of L1. So there are more to it. So we'll see in this slide. So it's not only hemivertebra, but all the more deformities. I just highlighted, but I'm not asking you to read that. So there will be absent pedicle. There will be so many congenital deformities. How do we tackle that? Simply get to fuse that segment. But before that, if there is a wedge, if you remember in olden days, एक कुल्हाड़ी जो मारते थे और wedge लगाते थे उसके ऊपर. So what happens? It opens up the space. So that's how this deformity of the spine comes in. So we need to remove that wedge from there. So we can do it anteriorly, you can do it posteriorly. This is a technique where we do it all posteriorly. That's safe because you don't need to open the diaphragm. So the respiratory system won't be affected. So we take that out, fuse it, and the baby, you can see the next slide, 5 days post-op. With a brace, baby is going home. Okay, of course, going home in the sense, 2 weeks we take out the stitches. So we'll stay in Delhi. That was in Max. So this is again, congenital kyphoscope. It's not that it's so easy that you fuse it and everything goes well. This is another baby, 8 years old female. Now, they had a kyphosis here with a hemivertebra. We operated that fusion, you can see. We did that. What happened? There was a dural leak, nothing. Next slide, you can see the MRI. There was a blockage of the CSF. That means there's a compression. Open it, fuse it anteriorly, fuse it posteriorly, we can do it. So what I'm saying is, don't get disappointed by the results. We can do it, whichever way we have to go. This is the congenital scoliosis again. The hemivertebra is in the thoracic region. This is again from Nigeria. So she came in with this. The main problem over here was, she's a young girl and she can't attend meetings, she can't be with the peer group. She's very conscious of her structure. So we did this surgery, we straightened her up. There's another deformity that needs to be tackled with the cervical spine. We'll do that later. This was in Max again. Neuromuscular scoliosis. What happens? The baby is all floppy. You can see on the wheelchair, the baby is like this, something like this. What's the problem here? The baby can't use the hand because of the floppy nature. What are we doing? We can straighten the spine, support it, so that at least the baby can use the head and the hands. So at least baby is independent. That is what my aim is. Aim is not to straighten the spine. Aim is to make them functional. That is what our aim is. So here we put in the implant and you can see. This is another person who came in Saket's Smart City. So this person had a scoliosis, neglected, okay, just because he was a patient whose father was a administrator or something like that. So I took that case up. This is a very stiff spine with fusion of ribs. So you can see the planning goes on. You don't have to put pedicle screws in all the vertebra, but you do a planning. 70% is what is advocated. 70% of pedicles you can fuse, and then it will be done. And then the next slide you will see, I had to cut many ribs also to free the space and see the patient is balanced. That is what we need. We don't need to straighten the spine. You can see it's not straight there. It's so much so that the head is balanced over pelvis. Next slide. So now coming to the adult part. This was all babies, coming to the adolescents, now coming to the adult. Very short. You can see how the progression of deformity is there. So you can see the facet loading that Dr. Vikas was talking all about, and you can see the curve getting progressive. Next. We don't have to fuse the whole spine. What we have here, with the scoliosis, you have a pinpoint where there's a compression. So what do? Decompress and a short segment fusion. That's all. Next slide. This is a lady, 52 years old female. Now she had this again from an adolescent's phase, but it went on to the adult scoliosis. And here we can see only the thoracic segment. We passed from the thoracic to the lumbar segment, and we did this fusion. That's the pre-op, where you can see the thing, and we could increase the height of the patient also. So that is the body consciousness, and we give her a proper image. I don't want to speak about the spondylolisthesis because Dr. Vikas has already eased my job. So 1, 2, they can do. Now this is a little bit about osteoporosis that Dr. Vikas was talking about. When you have a deformity with osteoporosis, you will have wedgings of the vertebra. So what you need to do is, you have to be very careful. Screw is not the solution. You screw it, the screw will come out. It's so weak, the bone is so weak. So you have to have, there are different options there, fenestrated screw where we can put in cements from there. And we try to fix this patient, and you can see the difference. And I restricted that to the lumbar region, because if you go to the thoracic region, that will be junctional area. We have other problems there, proximal junctional kyphosis, so we don't want to create more problems for the patient, we want a solution. Balloon kyphoplasty, Dr. Vikas had just said that we can do a segmental elevation and deformity correction. And we can also supplement with the screws and do an augmented kyphoplasty. You can see that has been curved with a localized kyphosis. You can put the thing right. Now, this is a challenge. Kyphoscoliosis, 75 years old female. Now, the life expectancy is increasing. Everybody. She was an officer, a very dominating officer. She wants to straight. She came to my OPD, rather Dr. Sachin Kandhari told me that this is the patient and see what you can do with it. Patient came with a lumbar belt and she's walking like this. What's happening? The center of gravity has been shifted back. That's why the patient can't walk properly. She's falling back. What you need to do, center of gravity comes between the feet. That is what? How do we do it? Let's try. And you can see the deformity, kyphoscoliosis on both. But on scanogram, that was the trick. When she is lying down, the deformity is much corrected. That means it's a deformity that can be corrected. Put a brace on, give her a chance, give her, and we are training with the advanced physio and the rehab team. They are training the patient to walk in, and she will be walking well. Let us see. If need be, then I might just have to take that lumbar segment, the lumbar curve, the scoliosis, and that we'll see after the bone is strengthened so that the screw can hold. Just a small segment and she can be straight and walking well. That's what I want. So what I want to say is, what the caterpillar calls the end of the world, deformity and was ab kuch nahi ho sakta. I'll tell you, there are patients that I have faced. I've just relocated from Sydney back here. And in these 3 months, I faced a situation where the doctor told that patient, spine hai, kuch nahi ho sakta, abhi chhod do isko. No. Where there's end of the world, God calls, gives you a butterfly. That's beautiful. Thank you.
Stay there, Priyadarshi. So, what a nice talk. Friends, if we have a spinal problem, so we know where to go. I hope none of us have.
Yes.
I hope none of us have. Okay, so Dr. Priyadarshi, tell us a little about what you talked about, deformities of the spine, scoliosis, lordosis, and kyphosis. Which is the commonest? Would you say the degenerative scoliosis, especially amongst the aging population?
So degen scoli is 2 to 32.
डॉक्टर साहब इधर बैठ जाइए.
2 to 32% in adult population. So, sir, before I start, let me tell you, this is the first place, Dr. Vikas, we are colleagues from long back. Okay, I'll tell you, I have been trying for this kind of association with Neuro and Ortho combined.
Wow.
And this has really, I have done my fellowships, US, UK, France, Australia. Those are the concepts that we can bring to this center, and I really commend Dr. Sachin Kandhari to give me a chance to be an association part of this. So I thank him for this. And for the question that adult degen scoli, that is 2 to 32%. And we have to differentiate between children, adolescents, and adults. So whatever comes
in the aging population, probably it's more degenerative scoliosis.
Again, I would like to draw your attention to that part where I said, if there is a scoliosis, we don't necessarily jump and correct it. We need to tackle the problem. If there's a simple pain by a compression of one, if you have a radiculopathy, why do you need to correct the deformity?
Right.
We take care of that radiculopathy.
So while we are still on orthopedic, Dr. Vikas, can we have the mic to him? So you talked about the degenerative discs, disease, and surgery indications would be severe pain, moderate to severe pain, severe spinal stenosis, not responsive, or failure, progressive motor and sensory loss. Would that be the indications?
Yes.
Right.
So motor loss, even what we commonly see in our practices is first and foremost thing is neurogenic claudication. A person with degenerative spine, mainly in the lumbar region, develops neurogenic claudication. That means he starts walking and is not able to walk for more than a defined distance. After that, he has to sit down. Because the reason is the veins are engorged when you walk, and there is no space for veins to accommodate the nerves along with them. And that is the reason you have tingling pain, heaviness in the leg. When you sit, the venous engorgement relieves and you are relieved. That is the first sign. And the distance keeps on decreasing. That is even the time when you have to go for surgery.
Great. So two types of arthroplasty, total disc prosthesis and nuclear disc prosthesis. So how do you differentiate, how do you go about?
Okay, so total disc replacement usually we practice in cervical spine, right? So there is indication because we need motion in there. So there are very good results with cervical disc replacement, right?
I believe one of the famous actors,
Shah Rukh Khan.
Yeah. So he had this thing?
Yeah, he had this thing with Dr. Alan Brocard in London. And way back. So there, he's just won a mascot that yes, he's the case of this. And it preserves motion. There is less of hospital stay. You don't need to apply collar after that. You can go around, you can play sports. And in lumbar region, earlier there were practices and studies of lumbar disc replacement. But actually in the long run, they have been totally discontinued because there is no advantage of that. Too invasive a procedure with disadvantage. But yes, fusion is the thing which actually is beneficial in lumbar region.
Right. So let's come to Dr. Kandhari. Always a pleasure to listen to you. So potential benefits for using robotics for rehabilitations are apparent. But there are some challenges, see, like cost, lack of high clinical evidence, and the need for standard protocol. Falls and fractures, they are bulky. What do you say?
So first and foremost, what our teacher used to tell us, every man should walk with you. We just cannot in today's day, 2022, we cannot accept mobility. You cannot walk. So we cannot, so as medical practitioners, our endeavor has to be to add to whatever recovery we can add and improve the quality of life. Cost, you consider the cost of somebody being paraplegic or incontinent or hemiplegic, the cost of, emotional cost of it, the substantial work cost of it, the vocational cost of it, it's going to much more surpass the cost of the treatment instead. The treatment doesn't take long, like 2-3 years, 4 years, it's few months or few weeks only, depending on the condition. Second, there's no alternative to this treatment. If you are actually hoping for neuro recovery, you want a promise like, this is me today, in 3 months can I be off the wheelchair or can I be off the walker? Can I use a stick or nothing at all? So that is feasible now. Before that, the people were, most of the money, the Superman and whatever, who got paralyzed, they had lots of money but no treatment. So I don't think cost is paramount in that case, that can always come one way or the other. Second, this is a new treatment, but it's an FDA approved treatment. That does not mean it is not scientific, it means it's scientifically approved. It has been approved to be fit for human use and provide the results as described.
Is there a standard protocol?
The standard protocols, yes. With the more and more use of these devices, we are able to make a set of protocols which can be replicated in different conditions. So that gives an advantage that now you are not therapist dependent, but you are the protocol dependent. The same model can be replicated for treatment of similar conditions in other centers. So we use a mix of not one device but 4 to 5 therapies, all based on the principle of neuroplasticity and reigniting the brain or retraining the brain. So instead of a passive physiotherapy where the therapist is coming every day for 6 years, morning, evening, taking a hand in one hand and holding it while talking on mobile on the other hand. So that doesn't need any results. You put some effort, you get results.
So let's go ahead, Dr. Kandhari, talking about neuromodulation. See, in 1967 was the year when the first neuromodulator, was invented and carried on. It's come far ahead now. For example, in Parkinson's disease, DBS probably relieves motor symptoms like tremors, bradykinesia, stiffness. And I'd like to ask you, how early could you start that? Would you wait for the drugs to fail and then start? Or what?
This is a very pertinent question as per the DBS. Let us consider DBS for Parkinson's, which is the most common indication. So, initial few years in DBS, the medicines work like wonder. So that is not the right time to choose for surgery. But then there is a sweet spot for surgery. So at least 4 to 6 years with medicine you can easily manage well without any complication. What if it is prolonged beyond 6 years or when even 4 years or 5 years, you get drug-induced dyskinesia, your symptoms worsen, your memory loss, or a degeneration. So it is the onus is on neurologist and the physician to monitor the symptoms and recommend to a functional neurosurgeon as soon as they see there is a decline in the response to medication. With a combination of 3 to 4 doses of Syndopa per day with a prolonged release Syndopa at night and 2 other drugs, they are not producing efficiency in that treatment, then you must recommend for DBS. I believe we say the first 5 years should be in medicine and then you should be capitalistic watch as to when you can require a DBS surgery.
Is there an upper age limit?
There is no cut-off limit. So because this surgery is done under local anesthesia, so there is no risk of any
minimally invasive, improves quality of life, and probably cost effective in the long run.
Yes.
Repeated hospitalizations also is reduced.
What is the cost of DBS, sir?
Yes.
The DBS, let's put it 2 ways. Now, if we have been exposed to DBS surgery in my training since 18 years now. It has evolved from using atlas and calculation of CT scan to keeping a newspaper, compass and scale and then deciding where the lead should reach. Now you have scientific methods of identifying where the lead in that nucleus is going to actually produce results or not. You can record microelectrodes, MER recording as they say. You can record the potential in the brain. The patient is awake, you can tell them to move their hand, limb, check for rigidity and tremors. And by navigation, you know precisely where you are going. And by navigation plan, you will avoid any untoward injury to the blood vessel which can cause a hematoma. So these are the complications for DBS which can be very much avoided much with the advent of technology. So the hospital has to be technically very efficient to carry out DBS in totality. The cost is then there's no indigenous battery for DBS as such, and we tried collaborating with somebody pre-COVID to make that battery, but he shifted to COVID PP6, so we are still without that. So we have tried using Abbott and other companies, but now for the last 6 years or so, or more than that, we are using Medtronic devices in all the modulation cases. So there are two kind of devices, three rather now, one that is just launched today, One is the non-rechargeable, that has a battery life of 3 to 4 years to 5 years depending on the current requirement. So if somebody needs a high voltage for stimulation, so battery will last in lesser period, so that's 3.5 years. And on the higher side it can go up in 5 to 6 years. After that you don't need to do any alteration to the leads in the brain, but just need to change the battery, which is a very small procedure, doesn't take more than 5 to 10 minutes. And the other device that they've launched is, it's a rechargeable and very thin battery.
What is the cost of that?
The non-rechargeable, the treatment cost comes to around 11 lakh rupees or so, 11 to 12 lakh rupees. And the rechargeable, no, there is no maintenance cost. The non-rechargeable, the maintenance is that you have to change the device after whenever it's over.
And
rechargeable one is wirelessly recharged, but there is no plug visible exterior. You just have to place a belt on the clavicle and it charges by itself once in 2 weeks. So that treatment costs around 16-17 lakh rupees in totality.
What is the oldest patient you have given DBS?
The age of the patient, 82 years.
82 years.
Youngest was 24.
My last question to you, Dr. Kandhari, would be on VNS. See, we know 1/3 of the epileptic patients are not responsive to AED, anti-epileptic drugs. So, is this the modality of choice?
See, VNS, the criteria are not very straightforward. Dr. Kishan will be able to elaborate that because we just come in the role when he says he is a neurologist. So we just cut his head on to that. Go ahead.
Actually, VNS is for very specific kind of patients. So normally what happens when we go for brain surgeries, in epilepsy surgeries basically, so we get a focus. Usually 20% of cases of epilepsy, they don't have any epileptic focus in MRI. So these are called basically idiopathic seizures, basically idiopathic epilepsies. So when we go further beyond MRI, like PET scan, SPECT, or any nuclide study, then we find some focus. And with help of long-term video EEG and all, we can just localize the epileptogenic focus. So we get a focus from where the epilepsy is originating. So in that case, we can just lesion out, or we can just remove that lesion, so that we can achieve a symptom-free epilepsy patient.
Right.
But VNS is after all this workup, and even after PET scan or even after the SPECT scan, we do not get any focus. In such kind of cases, it's a very specific population of patients in which we go for VNS. But VNS itself has its own side effects. It's not a 100% therapy. It can affect your voice because it put implants on your vagal nerve. But yeah, the results are very good as if the frequency of seizures are concerned, because we have seen patients who have daily 30 to 35 complex partial seizures. But with VNS, this modality, the seizure frequency have reduced to 1 or 2 per day.
So Dr. Chauhan has said we need to wind up in the next 10 minutes. So Dr. Kishan Raj.
And just one more point to add to this.
Yeah, please.
Since we're talking about VNS, so VNS is now recently been approved for stroke in patients.
Are you doing it?
We have tried now for the last 3 months non-invasive VNS. So we're doing VNS, yes.
What is the cost? What is the cost?
So the cost again depends on the kind of, but for simple cases, it will be around somewhere around 8.5 to 9 lakh rupees, because the device is costing around 6 lakh rupees. There's only one company in the world making that device, So now it has been FDA approved for treatment of upper limb function in stroke. So people who have a right limb dysfunction following left MC infarct and somebody who wants to use right hand properly. So it has been shown on the limb has the right or the upper limb to do more than 50% as compared to the massive therapist.
So finally, we are coming to the end of the talk and like to have Dr. Kishan talking on strokes. See, in COVID-19 patients, we have experienced a lot of strokes. Increased mortality, increased severity, large occlusion strokes. So, was this because of the activation of the coagulopathy plus the innate immune response which led to these large vessel strokes and higher mortality and severity? Please tell us.
Yeah, any infection has a effect on the coagulability of blood basically. So COVID had basically due to the autoimmune process and also in stroke, always the procoagulant factors in the blood they get activated and that leads to stroke. So normally we have the data which has come here. So basically if we talk about the post criteria, so we have seen a lot of small artery and lacunar infarcts rather than large artery disease. We have seen large artery disease patients only in patients who already had some other stenosis of atrial carotid artery or some vertebral artery disease earlier.
This is what the World Congress of Neurology, September 2021, said that in COVID-19, large vessel occlusions were more seen as compared to small vessel occlusions. And finally, tell us a little about, you showed one case, very interesting case of MCA occlusion. See, probably the modality of choice would be to do a thrombectomy, instead of a lytic therapy. Because malignant MCA has to be, tackled with a thrombectomy in place of a lysis. Majority of the cases would respond only to thrombectomy and not to lysis. Sir, that was an eye-opening case. I couldn't believe it. Please tell us, sir.
So, as per the guideline, first we have to give intravenous thrombolysis. We directly don't go for thrombectomy.
Sir, what is the agent of choice for thrombolysis?
It's Actylise. It's a tissue plasminogen activator. So it is given according to the weight. The dose is.
Same as RTP?
Yeah, this is RTP.
What is the cost, sir?
Sir, the cost is around for a 50 kg person, we give the dose comes down to be 45 mg. So the 50 mg vial costs 50,000 rupees.
You give it as a bolus or infusion?
No, sir, we give it 10%. We give it as a bolus, and the rest 90% in the infusion in the subsequent 1 hour.
1 hour. So,
sir, Dr. Tulsi, before you ask the question, sir, during COVID times, the stroke which Dr. Tulsi mentioned,
yes.
the kind of stroke that you witnessed, they were hemorrhagic more or thrombotic more?
More of ischemic, sir, more of thrombotic.
More of thrombotic stroke.
Yes.
Right, sir. And what was the success rate of thrombolizing these patients if they reached you, let's say, within good time?
So the success rate is like we can revert the deficit in only 30% of cases. Like somebody who has like the.
And what is the window period, sir?
So window period is up to 6 hours.
6 hours?
Yeah.
Okay.
But the earlier we thrombolize, the results are better. If somebody comes within 1.5 to 2 hours of onset of symptoms, you have the best results. If somebody comes at 6 hours, then it will be like we can halt the progression. Like if somebody has a power of 3/5 in upper limb and lower limb, so he might not go into a plegic condition. Like the power will not go to 0/5. The power will remain to 3/5. That can be later on achieved by physiotherapy.
The agent of choice is you said RTP. Can you also use tenecteplase?
Sir, we have actually the tenecteplase can be used, but we still do not have a convincing data of tenecteplase. Worldwide since 1995, the Actylise, which is from the Boehringer.
Are there any trials or tenecteplase?
So there are trials. Even DGCI, the government body has approved tenecteplase in our country also, but still we do not have any data to prove. Because we cannot give a patient a choice that what you want Actylise or tenecteplase that particular level car.
Sir, if the patient reaches you after 24 hours, then what do you use?
So we do not thrombolize that patient because the criteria is
So
only...
you don't thrombolize, but you still give him some antibiotics.
No antibiotic. Only we give ecospray.
That's all.
Yeah, there is no role of heparin. No role of heparin.
No role of
Heparin. Even heparin can cause intracerebral hemorrhages.
यार एक मिनट यार नवीन and any role of NOACs?
So NOACs can be given if there is cardiomyopathic stroke. Like if thrombus is coming from large arteries or it's coming from the cardiac. If the cause is like some...
At times you are not sure about the source. Sir.
No, when we work up, when we evaluate, we get to know whether because in the, I have not shown that slide, but when we evaluate about the stroke, we, apart from MRI, we go for MR angiography of the brain, neck vessels, and also 2D echo. This is the standard protocols which we do for every stroke patient. So we get to know, according to the TOST criteria, what kind of stroke it is. It is small disease, it's a lacunar stroke, or it's a large artery disease, or it's a cardioembolic.
So, to further answer the questions of our very distinguished Joan, so Dr. Raj, would you say the first 3 hours of giving lysis or lytic drugs, substantial benefits are seen. 3 to 4.5 hours, moderate benefits are seen. As Dr. Poddar would agree with me. And 3 to 9 hours, Dr. Joan, 3 to 9 hours, the window period for tissue risk and still salvageable. We could go ahead and do that. What?
Is 9 hours? Is 9 hours? Do you
The standard window period is 4.5 hours. This is the best. But up to 6 hours also we can thrombolize. Beyond that, we do not give any option of thrombolysis because thrombolysis has a risk of intracerebral hemorrhage in 6.5% cases, according to the LIMS criteria and the study done by EHE. In our population, in our Asian population, the data which has come in our Indian population, there is chances of, we have a less chance of hemorrhage, that is 3.5%.
Sir, Dr. Tulsi sir, just allow me one question for the benefit of everyone here. Sir, the vaccination issue for COVID has been very controversial. Have you witnessed vaccination related strokes?
No, I have not, immediate I have not seen, but I have seen after like 1 or 2 weeks, few patients I have seen.
Could you relate it? Could you correlate them to the vaccination?
So because we didn't have any other evidence, like we didn't have any cardiomyopathic source.
What is your take on that? Especially for people who have had previous strokes.
But the number is very less, sir.
Sir, my question is very specific. Your take on vaccination for COVID for people who have had documented previous strokes?
So there is no data on that. We can, but my advice is that they should go for vaccination because the people who are having stroke after vaccination, the number is very less. A very small amount of patients are having. So the benefit which we are getting of vaccination,
the risk benefit ratio is heavily in favor of taking vaccine.
It's heavily in favor of vaccination rather than.
Go ahead.
So what will be the protocol for TIE? Let me complete, please. So finally, my last question, Dr. Raj, as Dr. Chauhan asked, can tenecteplase replace alteplase? See, it's a very hypothetical question, and we know that tenecteplase is fibril, more fibril specific, has longer half-life, depletes fibrinogen to a lesser extent, and adjusts an IV bolus dose. And attest to trials have proved that there is no increased chances of intracranial hemorrhage, and the results are as good as RTPA. I don't know why it's not being done. Maybe there aren't enough sponsors, but probably you would answer more.
Sir, the numbers are still now in our population also. We do not have any comparative study between tenecteplase. One thing is that. Second thing is that the population studies which are done on tenecteplase, they are very less. Though the results are similar compared to injection actylize, but the studies to compare with actylize very less. And the particular situation when a patient comes to us, it's very hard. We cannot give an option to the patient whether you want tenecteplase or whether you want actylize.
Sir, is
Because
RTPA,
active is time tested.
kindly answer this question. Is RTPA more clot specific than inactive plates?
There is no study for that. You cannot tell this is more specific. This is because we as the clinical settings are or the clinical results are there, both have similar efficacy, but we do not have larger number of studies because LTPs have Cochrane studies, they have RCTs, they have meta-analysis.
Dr. Gandhi has
Dr. Gandhi, go ahead.
So what will be the protocol for TIA, transient ischemic?
TIA doesn't causes any ischemic infarct or any damage to the brain. It's just a transient episode. See, if some artery or some particular brain part it's been blocked for transient time, and after like a few seconds or few minutes, that clot is lysed. It's by itself it goes off or it moves upwards. So it doesn't causes any permanent damage. It's a transient symptom, but it has some basically prognosticating indication, like if somebody is having TIA, there is high chance, like 10 to 40% of chances of having stroke further in next 2 weeks. So he has to be evaluated and he has to put on ecospin.
Sir, we understand that TIA is at times called actually a dry run for a stroke later. So
it's a warning sign.
The patient should be investigated in full and honestly, as you would investigate any other stroke patient.
He has to go with MRI, he has to go with angiography of brain, he has to go with 2D echo that. These 4 investigations are compulsory in this case.
So we have some more questions, please.
Hey, you are keeping the silent mode, you are in silent mode. I would like to ask you, how about the Harrington instrumentation in kyphoscoliosis?
We started with the Harrington instrumentation, but what the problem was, it is just a single rod with 2 hooks on the proximal and a distal segment. So there is no support in between. So what used to happen was, the curve, if you remember the dollar sign, so the curve was like this and there's a straight rod. So that's a dollar sign. So that kind of instrumentation doesn't help to correct the deformity. Rather, it doesn't give you anchors at different points where you can fuse the thing. So very good, because that was the initial statement that we had. So we never, apni औकात को नहीं भूलनी चाहिए. So we always remember that and pray. अब हमारे पास इतने अच्छे instruments with the advancement of instrument and the pedicle screw rod system that we can do better than that. That is what it's advanced. Okay, but still, वो दादा पूर्वज को कभी नहीं मिला.
Another basic.
One of my friend underwent in 90s.
Another very basic. Our spinal surgery is neurosurgeon's jurisdiction or orthopedic surgeon?
Very good question, and I'll answer you that. That's the reason I'm saying this should be a collaborative effort. That is what I said.
So you are doing regularly.
So this should be a collaborative effort, and right from my fellowships, okay, Middlesbrough में किया UK में, they also, the head was Professor Grinoff, but they had Otto Soteris Papa Stefanu, who was with me. So those kind of a setup will give you a complete package. So if you have a structural deformity, I can help you better. But if it goes going beneath the dura, I will say, let my friend help you. Why not? So try to understand, you get a complete package and non-risky kind of operation. What will you prefer?
I think whoever is doing regularly, whether it is orthopedic or neurosurgery.
Sir, that was my question. I think Dr. Bhalla is asking that. Ask it regularly.
In PIVD, previously there used to be laminectomies. Okay? So, moment you do laminectomies, later on, there was always a spondylolisthesis. So, in every case, this spine should be fixed.
No, sir. And as you rightly said, laminectomy is the buzzword. But you should know what your limitations are. So you should not bugger with, I'm sorry to that word, you should not destroy the facet joint. That's what you have to be very careful about. If you have a 75 or 80 years old female, okay, let's say stenosis, why do you want to fix her up? how long, what is the life expectancy? Why do you want to waste your resources and give her a complication? Try to understand, if you fix it with the screws, the complication rates goes high. Do a laminectomy, middle laminectomy without destroying the facet joints, and you will get the same results.
This thing happened with my mother. She had laminectomy and spondylolisthesis later on, and she was on bed.
So I'll tell you why the problem was. The pars interarticularis would have been not intact. That is where the problem is. What you need to do is, you don't go to the pars interarticularis. Save that. If you can save that, there will be no deformity.
It should be limited to the area
So
where
there is a technique of doing it.
Yes.
So laminectomy is not a forced procedure.
This was done by a very renowned.
Sir, just one question. Sir, you showed some wonderful cases of kyphosis, scoliosis, kyphoscoliosis. We rarely see them, sir, honestly. And what I want to ask you, routinely we see prolapsed intervertebral discs, and I'm sure you are doing them.
Yes, sir.
It's like, you know, that wonderful program we used to see, Bharate Khoj, and then Tisco at Tata Iron Steel and Company used to say in the end, we also make steel. So I'm sure you are doing that.
Sir, I'll tell you, this is part and parcel of the.
You didn't show any case of a prolapsed intervertebral disc, which I think would have been your USP. I think you are an orthopedic surgeon, if I got it correct. You are not a neurosurgeon. So now I know that if I have a case of prolapsed intervertebral disc, I can send this case to IBS to you.
Sir.
And you will do it as good as you are doing those remarkable cases of kyphoscoliosis.
So the first case that I showed you was of a PIVD, and I said that despite having a scoliosis, you should not tackle the scoliosis.
You still had scoliosis, na, in that?
Yeah.
You didn't show me any. Yeah, 1 minute, yeah. Sir, Dr. Paul sir. Sir, question पूछ रहा हूँ. 2 minutes और sir. 2 minutes और sir, please. Sir, what I want to ask you is, if you have a plain simple case of PIVD L4, L5, how much does it cost to correct it in your setup?
Cost.
Yes, sir.
Okay. Simple PIVD might cost you 1.5 to 2 lakh.
How many days stay?
3 days.
3 days.
How much rehabilitation?
Don't have to, because you can go home and you can do the physical. Because we make the patient walk the next, or rather, if you do it in the morning, in the evening you can make the patient.
That is your USP, sir. That is your USP. I wanted you to display that USP. Sir, this is just a minute, sir. Just a minute. This is a.
आपने टॉपिक दिया था सर. आपने क्या बोला?
मैंने deformities दिया था.